Hello everyone. So we have a 43-year-old woman who come to the emergency department with abdominal pain and dark urine today in the morning. And when you examine the patient, you find there is right upper quadrant tenderness without guarding or rebound. Lab results, hemoglobin is reduced. Platelet count is of course, on the lower side of the normal. Total bilirubin is increased, LDH level is increased, even haptoglobin level is reduced. Okay. Well, when you do the further workup, you find MRI of the abdomen shows hepatic vein thrombosis because patient came with severe pain abdomen. What's the most likely diagnosis of this case? The answer to this question is paroxysmal nocturnal hemoglobinuria, option E, what we write as PNH. Now, before I discuss this question, unless you know the basic concept about PNH, you will never understand why the patient has this problem and why patient presented like this. Let's talk about basic concept about the PNH. Well, the basic concept is this is the blood vessel. Here is the RBC. Okay. And in the RBC, in the membrane, we have a protein. Okay. And to this protein is attached CD55, CD59. Okay. Well, this protein is GPI. This is an anchor protein. And this is holding these. Now, these protein CD55 and 59, they are the one which prevent, they are membrane protective proteins. Right? So now in the body, in the blood, there is complement. This is the complement. What I am C? C is complement. Right. Well, this C complement want to enter the RBC. This is the RBC. And of course, this is the blood vessel, as I mentioned, blood vessel. Now, this complement want to enter the RBC, but there are membrane protective proteins, so-called GPI and CD55, CD59. This complement cannot enter. Now, the basic problem of the PNH is that this GPI is not there. If no GPI, so definitely this will not be get attached, this will be absent. Well, now this complement can very well enter the RBCs and can lead to breakdown, and it will lead to intravascular hemolysis. Okay, the RBC breakdown will happen in the blood vessel. And now we know the basic pathophysiology of intravascular hemolytic anemia. HB get attached to haptoglobin. And that's the reason why haptoglobin level goes down, free haptoglobin level goes down, like in this patient also. Haptoglobin level is less than normal. A stage comes when the whole free haptoglobin has been consumed by joining to HB. Now HB will be filtered in the urine, and that will lead to hemoglobinuria. Hemoglobinuria will be there, and that gives a black color of urine. What happened in our patient also. Well, one more thing. The thing is, this happen at night only. This does not happen in the daytime. Now, the million-dollar question is why this happen in the night, not in the day? Yes, there's a reason behind that. Well, I told you this hemolysis going on, this process. This occur in acidic pH. Okay, this occur when acidic pH is there. When in the night when we sleep, we all tend to retain some amount of CO2. We tend to retain CO2. We retain, and that induces some amount of respiratory acidosis. As I told you, the complement get activated in acidic media, acidic pH, and that lead to hemolysis. In the daytime, this element is not there, so no hemolysis in the daytime. With the result, daytime urine is clear. Same patient who has come to you in the morning with black color urine, in the daytime, evening time, you take a sample, it will be clear. But again, the very next day morning urine sample will be black. That's a basic reason why patient has hemoglobinuria in the morning. Now, one more thing. This membrane defect, this not only in RBC, also in WBC, also in platelet. That means not only RBC, even WBC platelet will also be broken down. With the result, it will lead to, result will be pancytopenia. Like in our case, there is a platelet count is reduced, HB level are reduced because the reduced RBC count is there. The pancytopenia occurs. But point to be noted, we are getting pancytopenia, but the bone marrow is hypercellular. Okay, of course, with pancytopenia. Right? It's an acquired defect. It's not a congenital defect. With this background of basic concept, so we move further. So, what I was talking to you, normal cell, lovely picture, normal cell, we have GPI, CD55, CD59, complement is there, it cannot enter. So now in a case of PNH, GPI is not there, with the CD55, CD59 are not there, complement can enter. Beautiful picture, simple diagram, explain the whole pathogenesis. With this background, we talk more about hemolysis, anemia that lead to fatigue, pancytopenia, and venous thrombosis. This can be intra-abdominal and cerebral vein. This is a very, very important point. Why it gets an extra edge? Because in this we are getting low platelet, P for platelet count. And despite, in fact, usually whenever a low platelet count is there, that should lead to bleeding tendencies. Bleeding tendencies. But this here it is, despite low platelet count, it is more prone to clot formation, especially the venous clot formation. I'll talk more about this point in the coming slides. Now, patient ever question is most likely diagnosis PNH. Why? And of course, this usually occurs in fourth decade. Our patient is a lady of 43 years. That fits the criteria of the age also. Now, there are, in this patient, there are findings which are consistent with intravascular hemolytic anemia, like anemia is there. Well, that can happen in many other conditions. But low haptoglobin, this occurs only in intravascular. This is a golden word to remember. If you, any question, you get low haptoglobin level, okay, that means you are committed to intravascular hemolytic anemia. Elevated bilirubin and LDH, they can occur in any hemolysis. But this point goes in favor of intravascular hemolysis. Well, now why we are thinking in terms of PNH? Because of hepatic vein thrombosis. Okay, and with the signs of hemolysis. That's the reason why we are thinking in terms of PNH, because PNH is one type of hemolytic anemia which predisposed to thrombosis also. We'll talk more about this thing. Now look into this lovely ultrasound picture of hepatic vein thrombosis. Look into this. I can enlarge the picture for better visibility. I can remove also, right? Look into the hepatic vein thrombosis MRI. Look, lovely picture showing it here. Better I draw like this. This is a better thing to see, right? And now I enlarge the picture and I remove this also, so you can see lovely picture of hepatic. This is by MRI. Okay. So this what our patient developed, which was what was observed after MRI. Well, now PNH are a particular risk of developing within intra-abdominal or cerebral vein. But now question is, why clot forms in PNH despite low platelet count? Stop the video, write down the answer. Well, the answer to this question is thrombotic complication of PNH accounting for majority of the death. In fact, hepatic vein thrombosis lead to Budd-Chiari syndrome in as high as 40%, 41% almost. And cerebral vein and sinus thrombosis are the second most common cause of thrombosis. And in fact, this is rather one of the most common cause of death in patient of PNH. Okay. Now let's learn how this clot formation. Membrane-derived microparticles are formed. Okay. In the blood flow, the presence of high level of procoagulant microparticles, they are the procoagulant microparticle, and they are responsible for dissemination of prothrombotic states. Well, one more question for you. Which cancer can develop in these patients? Stop the video, write down the answer. The answer is they can develop AML. But one more thing you should know, this in some of the patients, they may even develop aplastic anemia also. Point to be remembered, these patients have a hypercellular bone marrow, but in some cases, patient may even go to aplastic anemia. Now, let's look into other option. Can it be acute intermittent porphyria? It may present with abdominal pain and dark urine, the way that this lady presented to us. But the pigment is due to porphyrin, and porphyrin precursor, not hemoglobinuria. And moreover, hematological abnormalities and thromboembolism are rare. They don't come with the hepatic vein thrombosis the way our patient has come. This is not a problem. Now, we talked about urine color. Again, I've got some question for you. Stop the video, write down the answer. You talked about urine color. Now, is there any difference between the urine color, something presentation, and what drug of choice is for acute hemolysis and prophylaxis for PNH? Okay. Well, now let's see. Look into this. We are getting a dark color urine. We are getting lighter. Okay. We are getting color variation. So in a case of PNH, the first morning urine sample will be like this, but evening will be like this. The clear color difference will be there. In fact, in porphyria, first morning urine sample is usually clear. But if you expose the urine to sunlight, it becomes dark. That means this is the PNH morning and this is the evening. But in porphyria, it is other way around. It will be in the morning, it will be like this, clear. But you expose the urine to sunlight, then it becomes like this, dark. Okay, but moreover, the color difference is there. In porphyria, slight brownish, but in case of hemoglobinuria, it's dark color of urine is there. But anyway, presentation is altogether different. Okay. As I told you, consecutive urine sample, you are getting different type of color. That's the classical that we get in PNH. Now there one more question for you. The drug of choice for acute hemolysis and prophylaxis for PNH. Stop the video, write down the answer. Well, the drug of choice for acute hemolysis is steroids. And for prophylaxis, we use eculizumab. Okay. Now let's talk about other option. Aplastic anemia, elevated LDL, bilirubin, they are the feature of hemolytic anemia. Low haptoglobin, what I told you is that intravascular hemolytic anemia. And these do never happen in aplastic anemia. So this option cannot be. Aplastic anemia in our case, of course, this can develop as a complication in some of the patient, but at least this is not the option. G6PD deficiency can lead to hemolytic anemia. Well, it occurs in male patients, particularly of African descent, but our patient is a 43-year-old woman, is automatically rules out. Patients are generally asymptomatic, and when there is no anemia, this can be triggered by medication or some infection. In fact, infection is the most common cause of predisposing factor, but many other medication like anti-malarial drugs, sulfur drugs are some of the predisposing drugs. And one more thing, fava bean are again predisposing factor. Venous thrombosis is unlikely in this patient, but in our case, patient has venous thrombosis. Now I've got some more questions for you. Stop the video, write down the answer. Can it occur in females also? Any chance? Remember, why it doesn't happen in female? Because it is X-linked recessive, X-linked disorder. But my question is, can it happen in females also? It's common in which part of the world? It lead to what type of hemolysis? Intravascular, or it is or extravascular? It's a protective against which infection? There are 4 questions for you. Lovely questions. Stop the video, write down the answer. Okay. Yeah. Can it occur in female also? Yes. It's rare, but can happen. Because it is a lady will have 2 eggs, and some patient, this one of the eggs may become inactive. Okay, this become inactive. That means only 1 egg is left, and 1 egg can induce hemolysis. This is known as lyonization. It's a very important question from genetics. So the normal X chromosome would be inactivated. As a result, the other X chromosome being affected, and that this will drastically reduce the G6PD level. So the only keyword to remember is lyonization. It's common in which part? Tropical Africa, most common location, Middle East, Greece, Italy, Asia. Well, look into this lovely picture that shows African country. You can see the percentage wise, dark green are the areas common. It lead to what type of hemolytic anemia? It lead to predominantly intravascular, but there can be some amount of extravascular, something unique, not a very common thing. It's one condition where we have both intra and extravascular hemolytic anemia. Okay. It's protective against which infection? Plasmodium falciparum, malaria infection. Now let's look into other options. Hereditary spherocytosis. It will lead to symptomatic, will be this mainly present in the childhood. It's an autosomal dominant condition. Our patient is 43 years. Manifesting at 43 is not a presentation of hereditary spherocytosis, so age-wise ruled out. And moreover, it doesn't have venous thrombosis. Again, I have a question for you. Stop the video, write down the answer. In hereditary spherocytosis, what happened to MCHC? Write down the answer. In this, MCHC is increase. Normally, in no other condition, MCHC increases. It will be normal or decrease, MCHC. But in hereditary spherocytosis, it is increase. Golden line to remember, should be suspected in patients who have a combination of hemolytic anemia, pancytopenia, despite having hypercellular bone marrow, hypercoagulable state, where patient can have intra abdominal or cerebral vein thrombosis. Flow cytometry are used to diagnose because that can get CD55 and CD59 on the surface. So flow cytometry, the diagnostic investigation. Thank you very much.